Hi, welcome to another OU Medicine Live Chat. I'm Teresa Green, so glad you're with us. We are joined today by Dr. Dale Bratzler with OU Physicians, also with the University of Oklahoma College of Public Health. So glad you're with us today.
Yeah, it's my pleasure.
We're going to be talking about a really interesting topic, and it's a shift in healthcare and also a shift in the training of healthcare professionals. It's called interprofessional learning. So let's start with the ABCs. You know, they hear interprofessional learning, big phrase. What does that mean?
Well, historically in the health professions, doctors, nurses, pharmacists, allied health professionals, social workers have all trained in their own colleges, but with the exception of small interactions during their training programs, they really didn't train together. So they might have a class together periodically, but often they didn't really learn to work as teams or work together until we actually put them in the healthcare setting. And so there's a big national push now that has recognized that health professions need to learn how to work together in teams, and we need to start that training while they're in their educational programs.
Which, as you said, is a shift. We're also seeing a shift in healthcare to monitoring outcomes. We don't just worry about, okay, let's do this treatment. We now want to make sure that ultimately the patient has a good outcome. My guess is that how well the health team works together has big implications for quality of care and outcomes ultimately.
Absolutely. So the healthcare system is really changing to one that's focused on value, which we define as high quality care at the lowest cost. And there's a much greater emphasis now on thinking about patient outcomes of their overall illness, which includes all the care that's given to them by all the professionals that are a part of the team. And so that's going to make us think about different ways to deliver care, to think about not only what happens when a patient's in a doctor's office or in a hospital or other settings of care, but how we coordinate that care across all settings to get the best outcomes for the patient. And so it's going to be very, very important for health professionals to understand the skill sets of other professionals that they may be working with and to know those strengths and competencies that they can actually use to improve patient outcomes over time.
So if you've ever had a loved one who's required complicated medical care, I think that was probably my first exposure to really, even though I worked around healthcare, when you're actually immersed in a situation and you're seeing all these different people come into play. And when I think about our situation, it was multiple doctors. There were nurses and nurse aides, but we had a whole gamut of therapy folks who were coming in. On top of that, at one point, we needed a dentist. I mean, there really, when you have a complicated situation, and we have a lot of people who are facing multiple health issues at the same time, it's important that all those people are talking and communicating.
Absolutely, very, very important that they're communicating well. If you look at a lot of research that's been over the years, some of the most common reasons that we have medical errors or complications of care is lack of good communication between health professionals. So communication skills is one of the core competencies for interprofessional education that we really focus on a lot. Now, the situation that you described sounds like a lot of hospital care where you do have a lot of professionals come in, but think about the patient that has complex illness but maybe doesn't need inpatient care. So now they're coordinating care between a physician's office, maybe a dietitian, perhaps a variety of different specialists. Maybe they need physical therapy and other interventions to improve their care. We have a very fragmented system, and when you work with a group of health professionals that aren't even in the same setting of care, it becomes increasingly complex to coordinate that care across multiple professionals.
And sometimes the systems don't talk to each other.
Absolutely.
Even the medical records don't necessarily carry through from one system to the other system.
That's right. So
helping students, this is what I wonder. I mean, we're tackling this at the level of these brand new people who are coming into all of these fields. what do we hope to accomplish, and how are we doing that? How are we bringing these folks together?
So here on the Oklahoma University Health Sciences Center campus, for the past 3 years, we've been doing a pilot program that was funded by the Wisdom Family Foundation, where we brought groups of students together from the 6 health professions colleges on this campus. So we included medical students and PA students. We included nursing, pharmacy, dentistry, allied health, and public health students. And then we also brought in the social work students from the OU Norman campus. And we ran a pilot for 2 years where we took a semester and we brought these groups of students together. We assigned them to teams that were interprofessional, so they didn't get to all set with the people they knew. And we spent a semester thinking about, how do you do teamwork? How do you communicate between health professions? One of the things we learned very quickly is that many of the health profession students didn't know anything about the training program for the other health profession students on the same campus. They really didn't understand what their training was and what they were expected to do and what they could do, what their competencies were in healthcare. So we spent a semester doing that, and then we took them to a clinic, a free clinic, where the student teams were given complex patients. We hand-selected a certain group of patients, and we asked them to actually coordinate care as a team of students. So think about a team of 10 students from all these different disciplines going in to evaluate a patient. And what we found was it was transformative for those health profession students. Their perceptions of what healthcare should look like changed dramatically in that semester that they were actually seeing patients together, because they learned of the skill sets and the competencies of all the other health professions that they'd be working with. And it truly changed, I think, their perceptions of what you could do in healthcare. That was our pilot. But we could only do that with about 80 students per year. And there are something like 3,500 students each year on this campus. And so we had to figure out how to scale that up, that experience up. So this year we had our first All Professions Day, where we brought one class from every college together. And over a period of 2 days, we brought together 831 students. We did 1 day in the fall semester, 1 day in the spring semester. All of these students came together. Once again, they were assigned to student teams of about 10 students, interprofessional once again. And we spent the first day focused a lot on competencies for interprofessional training. Those included things like, what are roles and responsibilities in healthcare? We actually had the students do interprofessional speed dating. And
that sounds interesting.
Yeah, interprofessional speed dating, which was fun because here what we expected the students to learn in a short period of time was, tell me about your training, tell me about what you expect to be doing with your career, and what skill sets you'll have at the end. The students found that very, very interesting to learn about the other professions.
In a very short period of time.
In a very short period of time.
They were exposed to multiple professions.
Multiple professions. We taught them team building skills, and we had them do some team activities. So we taught them the competencies that they need to understand to work together as interprofessional teams. It was really about team building. How do you get groups of professionals together and come up with a cohesive team that can actually deliver care? I'm
curious, before we go into the next then, so what sorts of team building activities do you use to encourage these individuals to work together? How do you do that?
So we did 2 different things. So we give them some activities to do as teams at their tables. So we actually had a variety of games even. We've used hula hoops. We've used a variety of different games that we do that actually require the entire team to function together at the same time. And they have to communicate well to successfully complete these team building activities. So they learn how to communicate together, develop a common language. What we often find is that someone has to figure out how to be the leader of the team, and somebody has to coordinate the activities of the team. So we did some simple but fun interactions at the tables that helped them learn how to work together, and the recognition that the entire team functioned only as well as each of the individual members of the team. After we completed that session in the fall, we asked the student teams to go out into the community and do a charitable project. We gave them a list of activities that they could think about, but we called it our inter-session learning activity, where they actually had to pick a charitable organization and go out as a team, coordinate that activity, and as a team come together and go out and complete a charitable activity. After they did that, then we brought them back for that second day of interprofessional learning, where we focused on clinical vignettes. We presented difficult, complex patient issues and asked them as a team to think about how they would address the patient's needs. We asked them to set up goals for the patients that we presented, and then come up with care plans. What was very interesting in that process was we presented complex cases. We actually brought a real patient on stage and had several of the faculty interview this patient to give the students enough of the history of this patient to truly understand how complex their care was and how their medical issues had so profoundly impacted the patient's social circumstances, loss of job, so many different things. Living circumstances, and also the complexities of dealing with complex illness when you have very little income and other very challenging social issues that are so common in healthcare. The students then had to develop plans for how they would address some of that. What was very interesting, even though we presented patients, the two scenarios that we presented were complex medical issues, most of the goals for treatment that the student teams came up with were to deal with many of the social determinant issues for the patient. They really didn't focus a lot on changing medicines or doing more tests. They recognized that the real root of the patient's problems were the many social issues that were affecting them. So clearly there were medical issues that needed to be addressed, but they also recognized that there was a whole lot more to the patient's care. They understood the context that the patient lived in, and their care plans reflected that.
You know, there's a phrase, we say it takes a village to raise a child, but more and more I think it takes a village to keep a person healthy. It takes community, it takes, not just the medical community. We look beyond that to what community support services we may have. Because a lot of chronic health issues require not just what's done in the doctor's office or in the hospital, it has to do with everything that happens outside of that.
Absolutely. So think about a patient who has several complex illnesses or complicated illnesses like diabetes, high blood pressure, maybe high lipids, and other, maybe heart disease. Those patients have lots of needs. They're in the physician's office for a minimum amount of the time. And we expect them to go out then into the community and take care of all of those complex illnesses without the direct supervision of the physician at that time. So what the students I think quickly have learned that to actually coordinate the care for a patient, you really have to think about the context of the patient's illness and their living circumstances and everything else, their ability to get medications, their access to transportation to get to a physician's office, their understanding of the medications, the interaction of medications with their social circumstances, with their diet and other things. There's so many things that affect health for a patient that go beyond just the acute medical interventions that we so often in our current healthcare system tend to focus on.
You talked about something early on, and you talked about communication. As a team, you're not only communicating with one another, but all of you are communicating with the patient as well. And that's sometimes confusing to the patient, I would imagine.
Yes.
So I would think that the team has to come together and figure out, how do we communicate these issues best to each patient, correct? And who's the best member of the team to communicate this information?
Right. So I think one of the things the students learn in the clinic setting fairly quickly is that you do have to have someone that's coordinating all of the activities for all of the health professions that are available. So when we're in clinic with one of these teams, and we'll have perhaps 10 students of different disciplines all sitting together, one of the things that they have to do is they have to think about okay, now how are we going to get a cohesive message to the patient and make sure that we're not just simply confusing the patient? So a lot of our teams, they come up with interesting ideas of ways to consolidate the information from all the health professionals and come up with a cohesive set of instructions and educational programs. And sometimes one of the things that comes up very quickly is that when they bring the patient back, they recognize the patient really doesn't need to see 10 different disciplines, but there may be 2 or 3, and it may not be the physician that they really need to focus their time with. So in clinic last week, we saw a patient that they're bringing back, but they're going to spend most of the time with the physical therapy student and the clinical dietitian, because those are the needs that are most important to the patient at this time.
I had an opportunity to interview a number of the students who completed the program last year, and all of them, every single one I talked to, said that this experience was by far, they felt, the most important experience they've received in their entire education.
So I think that was the experience that we got from the first 2 years of the pilot, that the students that had that opportunity to do the team building activities, to go through the didactic portion, the active learning sessions that we did, and then go on into the clinic setting and work together as an interprofessional team, it truly was transformative. And we have quite a bit of evidence now that it really changes their perceptions of what healthcare could or should look like. I think our challenge here on this Health Sciences Center campus, where we have so many students, is how do you replicate that interprofessional learning across so many different students. We can bring them together, and we've done that with the didactic sessions, and we sent them into the community to do charitable projects, and we put them in a room and walk through clinical vignettes, challenging clinical vignettes. But one of the questions that we have as a faculty is, will that experience be the same as then going into a clinical setting, working as an interprofessional team, where you're actually sitting there across the table from the students from all the other disciplines? You know, one of the interesting things we found when we did this the first year was that we asked the students, which profession did you gain the most respect for through this experience? You know, how did your perceptions change? And what we found probably wasn't too surprising. I mean, physicians understood the role of nurses pretty well, and physicians understood the role of a pharmacist and others. But the two professions that most of the other professional students really didn't understand how important they were social work, how important it was, because all of a sudden the students recognized that the complex social determinants of health were really impactful to patients, and the social work students were very helpful there. And then the dental students, because there are so many dental issues that the students had no idea impacted patients' health. For instance, keeping a diabetic patient in control. If the students didn't recognize that the patient couldn't eat the foods that they were recommending because they were having dental issues, until you address those issues, you weren't necessarily going to get the patient's diabetes under control. So they gained a great deal of respect for these other professions.
Wow. One of the things that I wonder about is we are seeing more interprofessional learning here and across the country. We're hearing more about this. We talk about reform in healthcare. Are we going to see, moving forward, changes, you know, as we move forward in the way we deliver education in all of these professions? Is the structure that we currently have going to look different maybe 10, 15, 20 years down the road?
Yeah, I think it will. I think it'll be a slow process because, as you're aware, both in healthcare that we deliver now, we have a system that's been built over many, many years that is focused on paying in silos. We pay for physicians, we pay for the care we give in hospitals, we pay for the visits that patients do with other health professionals. What we haven't done is had a system that rewarded this concept of coordinating care to keep the patient healthy. We've focused on taking care of the patient when they're sick. And so I think that's where we really have to think about different ways to deliver health education. So one of the things that's happened now nationally is that in almost all health professions, the accreditation requirements to actually be a college of nursing or dentistry or pharmacy or medicine or public health is that you can demonstrate that you give interprofessional learning opportunities to your students. You have to have that now to be an accredited training program. So we are all on this campus certainly working to think about how we do that, how we build more clinical experiences for the students in an interprofessional setting so that they can learn how to work together as teams. And right now we're in that transition where healthcare is moving from kind of the old system where the more you did, the more you billed for, you got paid, and that we tended to be very focused and siloed, and to a system that's going to reward us if we coordinate care, keep patients healthy, perhaps deliver fewer healthcare services. And so as that system changes, I think there will be more and more opportunities for students to learn in that setting of care that asks them to coordinate and work together in those settings.
You've done a lot of work on quality. You know, a lot of your research focuses on quality. Do we know that whether or not bringing and aligning care and more closely integrating care and improving communication and creating these teams, do we know that it positively impacts outcomes?
Yeah, so I think we know very well that when you have more coordinated care, you can reduce utilization of healthcare services. That's been demonstrated very well, that you can reduce cost of care, reduce unnecessary hospitalizations, emergency department visits, care. There is preliminary evidence that as we do a better job of coordinating overall patient care, patient outcomes can actually be better. Remember that when patients get hospitalized, it's usually because they become acutely ill. So if we can prevent those circumstances, patient health care will actually better. They'll have better experiences. They'll have better quality of life. And hopefully we can reduce mortality and complications of care by coordinating across interprofessional teams.
I may be oversimplifying this, but I sort of think of the system we're moving away from as being the system where we wait until it's broken and then we fix it. And we're now moving more towards a system where if it was your car, we're going to have those regular oil changes, and we're going to check the air pressure in our tires, and we're going to make sure that everything's running just as well as it possibly can. I mean, we can't obviously prevent some surprise from happening with our car, but we do the best we can to avoid that. Oversimplifying what we're looking for?
No, I think it's actually a very good analogy. So one of the things I teach when I'm in public health is that the United States has the best sick care system in the world. We truly have a system. If you have a complex case, if you have a complex cancer, sure, you want to receive care in the United States because we have a system that focuses on high-tech care, complex care, specialty care, hospital care. We do those things really well. What we don't do well in this country is keep people healthy in the first place. Focus on the things that would keep them from getting to that level of needing such acute, complex care in the first place. So we need to figure out how to promote health and do that more effectively. And there are a number of payment models that are now being proposed, not only nationally, but also in Oklahoma, that will start to focus the healthcare resources in the community setting to actually keep patients healthy so that they don't require it. There was some nice work done a few years ago that looked at patient populations that showed that, there are some patients who almost never use healthcare services. They generally tend to be healthy. That's probably 50% of most people rarely use healthcare services because they're relatively healthy, they have healthy lifestyles, and they just don't utilize the healthcare system. There are a number of patients who you'll never be able to predict those illnesses, that we're always going to need that acute care for. Those are patients that have trauma or certain life experiences, genetic diseases, cancers that we can't predict today. We don't know how to prevent, and we can't predict. Hopefully that'll change over time, but right now, there are just going to be certain patients who develop illnesses that no physician or other health profession is going to be able to predict necessarily. But there's this large population of patients who have difficult diseases. Maybe they're pre-diabetic, they're overweight, maybe they're a smoker, or they go on to develop things like diabetes and hypertension, where they use a lot of health resources, And we know that right now their care tends to be fragmented and not coordinated well. And that's the population, I think, that we at OU physicians and others are really starting to think about how we impact this population of patients who are at risk, who are at risk of going on to develop acute illness. How can we keep them healthy? How can we help them with their lifestyle?
One of the things that I liked about what you did also in the training, because one of the things that I think about is the patient. Each of us is a very important element in how well we're going to do, because we get a lot of information when we're in the doctor's office, and while we're in the doctor's office, we shake our head and say, yes, 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 I should do all of those things. But then we get out of the doctor's office, and one of the things that I liked is you brought real patients in to share perspective, because the patient becomes a part of the team too, correct?
Yes, yeah, very, very important. And one of the skills we try to teach, particularly as we think about the ethics and values of patient care, is that it should be patient-centered, that the patient's perspective has to be considered. One of my pet peeves in medicine is when we call patients non-compliant. And I'm not going to sit here and say that we never have patients that don't do what we ask them to do, but I think all too often in healthcare, we ask patients to leave the office and go out, and we give them a list of instructions, medications, diet instructions, and things like that, without a good understanding of the patient context, their circumstances. And so the question always becomes then, if you were in that patient's shoes, could you do all of those things? And oftentimes, I think that's what the students learn when we're in the clinic setting, is that we can do all of this. We have great ideas. I tell the students, in your training, you've learned what the patient needs based on evidence, guidelines, medical studies, and other things. You know what they need, but that doesn't necessarily mean that that patient actually wants to do those things, or that they're capable of doing them. So we can prescribe medications, but if they can't afford them or get them, they're not going to change. They're not going to take the medications. If we give them dietary instructions, but they live in a neighborhood where there are no grocery stores with healthy foods, they're not going to be able to comply with our instructions. So I think that's a big focus, is starting to learn patient context and the other factors that are impacting their health, because most patients, I don't think, actively want to not do what we ask them to do, but we oftentimes, in a very short period of time, give them a list of instructions of things to do in that short 15-minute office visit, or at the time we discharge them from a hospital, and then they go home and they're not capable, they don't have the resources or the ability to do the list of things that we've asked them to do.
I've even talked with dietitians through the years who say, we make assumptions that when I say this, people know how to do that. And, core and quarter an apple. You say that to some people, they have no idea what you mean. And so you have to sometimes give them resources that are going to help teach them to have the basic skills to prepare healthier foods, or to even how to purchase them.
Right.
If you've never shopped the grocery store that way and you've never prepared food from scratch, we could say, hey, go out and eat these healthy foods, as you know, and all of us know, 5 servings of fruits and vegetables a day. But if you've never eaten that way, and you tend to buy things that are prepared and that you can cook quickly, that's a lifestyle change,
right.
And that requires accessing additional resources.
Absolutely. The other thing that we've learned is that oftentimes, even in some of our educational programs, so I'll use the clinical dietitian as an example. If that clinical dietitian doesn't have the understanding of the patient's culture, perhaps their culture is completely not compatible with the instructions that we may give them. So that became clear in a clinic that works with primarily Hispanic patients, that the clinical dietitians have to understand that culture to a certain extent and adjust their educational programs to address the types of foods that are going to be common in that culture. So having cultural competence is also very important. One of the things we learned on the whole, because we saw so many diabetic patients with the students, one of the things I think they quickly became familiar with when they started asking them about where do you buy your food, that there are many of our patients, and these are complex, uninsured patients that we take the students to work with, that live in neighborhoods where there are no grocery stores, that a convenience store may be the shopping place for food, and as you know, that's not particularly conducive to healthy living. And if they want to go to a grocery store, then they have to figure out a way to get transportation, whether it's taking a bus, which may or may not be available. They may not have the transportation needs. So there are many things that make healthcare for these patients very complex. The other thing that came out in the clinical vignette we did with the students on stage was that the healthier foods are more expensive. And this particular patient and others oftentimes can't afford, or they are on limited resources.
We're about out of time, so I think we've hit so many important issues on this. One of the things that I wonder is, as you work with these young people, does it make you very hopeful for the future as you see them go through these programs?
Yeah, absolutely. I'm really hopeful for the whole U.S. healthcare system as we start to transform to one that really focuses on patient outcomes and value in healthcare. That we move a little bit away from the mindset that it's always about doing the most extensive, acute, invasive, complex things. Those are important when patients need them, but we have to, as a society, figure out how to do a better job of keeping our patients healthy. And I think with a very dedicated faculty, I want to highlight that we have a dedicated faculty from across this entire Health Sciences Center campus now that have been working on this for the past 4 years, to figure out ways to expose the students to that. And I think they understand it. I think they recognize that there are so many other complex things that happen when we're taking care of patients who have complex illness and other things. We really, as a society, have to start figuring out, and as health professionals, to keep the patients healthy in the first place. That's our obligation in healthcare, is to work on promoting health. So it's a transformation of not only the health system, but also the healthcare educational system.
And I feel like these students are going out better prepared for what they're going to face in the real world.
I think so.
They get out of school and they have hopefully a better understanding of what the other professions do and maybe how to work together, which ultimately we hope will lead to a benefit for the patient.
Absolutely.
Okay. Dr. Dale Bratzler, thank you for your time.
Thank you.
We appreciate your time. Do join us for the next OU Medicine Live Chat. Have a great day.